We are getting into respiratory drugs, and hopefully this slideshow is the same as what you have. Um, so what makes up our respiratory system? Airway. That's our biggest thing, right? Everywhere I am breathing and everything that is affecting, right? So my nose, my mouth, my trachea, my bronchioles, my lungs, all of those things are included in my respiratory system. Okay. So what are potential complications? And biggest things that I could tell y'all would be blockages, right? That would be really bad. Cancer, 100%. Inflammation is going to be a big one that we discuss. And I thought of something else and then it left me. Infection, those sorts of things are what is going to mainly what we are going to be discussing, okay? But anything that is impairing our airway is going to affect our respiratory system, okay? If our respiratory system is affected, what's not happening? To some degree, right? I might be, I might have decreased perfusion, that's correct. And so what am I monitoring? Yes. Lung sounds, respiratory rate, O2 sat, their cap refill, I, their perfusion, right? I am looking at them and observing even their work of breathing. If somebody has an acute asthma attack, I feel like if you have never witnessed that, experienced it, you've seen a picture of what that looks like. It is very clear that person is not getting good airflow, okay? So assessment of my patient is going to be very important. So what is my goal? Breathing. That's the goal. Okay. Optimal breathing. So if I am administering medications that are affecting that, I'm worried about their adequate breathing, right? And then we'll talk about lots of different complications that can occur from that. But Um, that is what I am monitoring. As far as how I'm going to know is it's working, I've already said what we're looking at, right? I should hear clear lung sounds. I should see a decreased work of breathing. I should see an adequate cap refill. I should see a O2 sat within a stable range. I should have a respiratory rate where the patient is not under distress. Okay, so all of those things is what I am looking for. Um, so just to give you a visual, even if you have bronchitis, when there is mucus and irritating and blocking your airway, you have impaired airflow, right? So that is what that looks like. And then I put this picture here. I am not going through all of these, but the gist is inflammation, okay? I feel like every single day in patho, we talked about inflammation. This is the same deal. All depending on if they have asthma, if they have an infection, if they have COPD, if they have emphysema, if they have allergic rhinitis, all those things, inflammation is our problem, okay? So, all of these are the different kinds of medications, the classifications that treat respiratory disorders that we're going to discuss. Okay, so I have it broken down for the most part. This is my little just side note of some of these things overlap. Okay, but for asthma and COPD, the drugs that we're going to discuss are anti-inflammatories and bronchodilators. Okay? Before we go any further, what is an anti-inflammatory going to do? Y'all got it. What is a bronchodilator going to do? Okay. It is dilating bronchioles, right? So that I just feel like even those very simple little words, if you really think about what that means, is going to make sense of what they do and what you would be worried about. Okay? So the types that we're going to discuss, we're back. Here we are again with our glucocorticoids, okay? In this instance, we are not giving this because they are deficient in cortisol, okay? We are giving this because we're treating inflammation, okay? For bronchodilators, we are talking about beta-2 agonist, okay? So we can give medications in different ways. One of the ways that we can administer medications is through inhalation, and there are different ways we can do that. I have some different examples. So here is a nebulizer. Has anybody never seen a nebulizer before? Great. Well, if you have to administer this, you connect it to oxygen. Lots of times little babies have these at home, the little kids when they're sick. Or you can administer these in the hospital. They have little tubes of medication, liquid medication. You pour in this little chamber here. I open this up, pour this in here. I connect it, put this on their face. They inhale the medication. Okay? That's a nebulizer. They also can have different kinds of inhalers. So we have like dry powder inhalers, which this isn't open, but you can see, yes. So they have in little Advair discus, there are pills containing powder that come with these discs. You put the pill in the disc, you smush it, and then you inhale the medication, okay? So you're inhaling the powder. You do not take the pill by mouth, okay? Then we have inhalers. So I will show y'all a picture. I can't remember if it's on the next slide or coming up, but I shake an inhaler. You put it to your mouth. Make sure you breathe out first, all the way out. Put it in, breathe in, and then I hold it for 10 seconds. Okay, that's me using an inhaler. And then I don't have examples of those, but for the metered dose inhalers, that is literally by a dose. Okay, so those are the different forms. The benefit of this is it's acting directly on my lungs. Okay, so the systemic effects of that type of medication are minimized because it's basically locally acting on my lungs, my bronchioles, whatever, my airway, okay? So if I'm having an acute bronchospasm and I'm giving a medication that is going to dilate that, please give me something that is acting directly on my lungs, right? That's what I want first, so that can just locally dilate my bronchioles, get me some air, okay? So that a rescue inhaler is a beta-2 adrenergic agonist. Albuterol is a rescue inhaler. So I will point out, it's not specified on this slide. It is a little bit later on, but there are short-acting and there are long-acting beta-2 adrenergic agonists, okay? They function to relax smooth muscle, which is how they dilate my bronchioles, okay? So, albuterol is a short-acting. That is why I use it as a rescue inhaler. Salmeterol, that would be the prototype for the long-acting, okay? So those would be used at different times. So I use this, the short-acting in acute asthma attacks for bronchospasms. The long-acting can be used more long-term just to control symptoms of asthma, okay? Adverse effects of this. Have any of you never used an inhaler? But pretty much immediately, I mean, it is very, very quickly, you start having like palpitations. Your heart rate goes up, okay? So your heart rate goes up. Very common side effect with this is tremors. I actually was very sick and was continuing to teach one time and wasn't even paying attention. I was dying to use my inhaler, went up to started teaching, and I'm like, and I'm like, they think I'm on drugs. Okay, great. So that is a huge complication, or very common complication with the short-acting albuterol. And this can be given orally. For rescue inhalers, those are giving inhaled. Okay. Yes, that's possible. You don't give it to them. You would give steroids. They just won't work as effectively. You might have to intubate, just depending. For the because that is how this is impacting. If my patient has cardiovascular issues, if they're at risk for an MI, if they have impaired circulation, um, I'm giving them something, or if they have heart disease, renal disease, that can this could be contraindicated with them. Okay, so here is a little um, explanation of how you do this. So make sure when you're teaching somebody to use this, or if you're using it the first time, you prime their medication. So before the first time that you use it, you squeeze it out to make sure, like, you get a puff before you ever use it. Okay. So I make sure that I prime that. You make sure you shake it really, really good. If they have a spacer, I looked for one in the lab and I didn't see one, but this is what it looks like. The purpose of that is just try to help it get it lower in the lungs. Okay. So make sure that they are standing up and then are sitting up straight, and then they are breathing out all the way out. They use the medication and they breathe in. Okay. And then usually you want to tell them to try to hold their breath for like 10 seconds. Okay. And then they can take it out, they can release it. If they have to do another one, then they need to wait a few minutes before they do their next one. Okay. If they are taking a medication after this, like if they're using this in conjunction with an inhaled steroid, they need to wait like 5 minutes before they use it. Okay. But before they do the steroid. Um, any questions on this? For the steroid inhale, that's more of a big deal because the steroid can increase sugar, which increases infection, so they could get thrush. So rinsing their mouth is a bigger deal with steroid inhalations. Correct. But wouldn't hurt. So the next thing that we're going to talk about is methylxanthine. Our prototype for this is theophylline. This is used for more long term. This is not used for emergency treatment. And it also causes smooth muscle relaxation. Side effects of this are restlessness, insomnia, nausea, vomiting, diarrhea. Big deal with this is there is a very narrow therapeutic window. So, so it is very easy for them to have toxic effects of this, which can be life-threatening, cause them to have seizures and dysrhythmias that could kill them. Because of that, it will be very important for me to do what? Hmm? So I get where you're going. Let's say that we'll start low, right? Like we'll start low until they can get therapeutic effects if I absolutely have to give this. Wouldn't be my first line treatment, right? Also monitor their drug level. That is going to be very important with administering this. Make sure that they don't have toxic levels. The uh, I can't remember what I was going to say. I lost my train of thought. So sorry. This isn't given very commonly because it is there's such a narrow window and the severe side of it. Okay. Next, we're getting into anticholinergics. So these can be given by an inhaler or by a nebulizer. So these can be used if somebody has bronchospasm caused by allergens, or if they have exercise-induced bronchospasms. These work by blocking the muscarinic receptors of the bronchi, causing bronchodilation. So all these are kind of doing the same thing, just in a different way. Side effects are dry mouth and hoarseness. This again, if they have an allergy to peanuts, we want to use caution. Same concerns with narrow angle glaucoma and BPH. Usually you give this 2 puffs if it's by inhalation, and you do want to make sure that they rinse their mouth. This is commonly given to people who have COPD. This is not a rescue inhaler, okay? The anticholinergics, who knows what they do? They they the memory for this that you're paying attention to when you're administering anticholinergic, and we're coming back to this in a minute, is you can't pee, you can't see, you can't spit, you can't not saying it. Okay? That everything's gonna be dry. Okay, so that is a potential complication of this, is they're going to be constipated, they're going to have dry mouth, they're going to not be urinating enough. Okay, so that's right. Can't see, they have blurred vision, can't poop.
It's not can't can't see, can't treat this time.
No. Go for it though. um, so we have, that is what we're watching for. So what would I want to teach these patients? Drink water. A lot of times what you'll see is you'll tell somebody to like chew on candy or something, right? You don't want them to have maybe sugar-free candy, but something to keep their mouth moist. All right. And then tachycardia and restlessness are other side effects that can occur. Maybe. I don't know. Sour stuff makes my mouth more dry.
Really?
Yeah. Uh-huh. Sure, go for it. Again. So glucocorticoids for asthma treatment. The common are beclomethasone, which is inhaled, if you have an inhaled glucocorticoid, or prednisone is a pill. Okay. Like I said, if you're administering this for an asthma attack, I give the beta 2 first. I'm going to give my albuterol first, wait 5 minutes, then I give the glucocorticoid. Okay. It can be inhaled for long-term asthma prophylaxis, short-term for acute asthma, and then if people have more chronic severe, they take oral prednisone. Okay. It also, when babies are born prematurely, this is given to help stimulate their lung maturity and to make sure to decrease that respiratory distress. So these are going to prevent inflammation, also suppress our mucus production, and then help that beta 2 work more effectively. So there is going to be a reduction in that swelling and in the mucus. Okay. So once again, if somebody is taking this, I wouldn't want to give them a live vaccine. Okay. Um, Also use cautiously in children with diabetes, because we said that this can cause their blood sugar to go up, as well as people with infections or who are at risk, because we said that this is going to suppress their immune system. And if they have osteoporosis, because remember that long-term therapy can cause that, and then kidney dysfunction. With this, like John said, we're going to make sure that they rinse their mouth. Because of that sugar accumulation, they're going to be at risk for oral yeast infection. If they had that, does anybody know what you treat that with? Antifungal. So I give them antifungals, and most of the time, nystatin is what they'll get. And it's either, depending on the doctor, they'll teach them to swish it and spit or swish and swallow the nystatin for to directly, basically, topically affect the yeast infection in their mouth. So, what would that look like? White patches might be red, might be irritated. Okay, so that would be a bad sign. Um, could have hoarseness, difficulty speaking, adrenal suppression, because we said that this is replacing the adrenal function, right? So my adrenals might go to sleep. So if I just abruptly stop taking this, they might not function like they're supposed to. Okay, so tapering would be important with this also. Um, Same deal, muscle wasting, bone demineralization, high blood sugar, peptic ulcer disease. We've talked about the other things. If it's nasally, which again, we're coming back to this in a second, with nasally, they're going to be at risk for nosebleeds. That's what this word means, epistaxis, sore throat or headache. It can be given meter dose inhaler, nebulizer, orally, nasally, and usually for treatment, they're going to have like within 30 days. You don't want people to be on these long term unless they absolutely have to for because they can't breathe, right? We would like to avoid this because of the severe complications that can occur. So again, if they're on this long term, then their body has suppressed that function. So same thing, if they're under stress, they might need increased doses. Okay, even though maybe that's not exactly why you're given that. Um, all right, now leukotriene modifiers. The prototype for this is Monteliacast or Singulair. This is used for long-term control of asthma, also nasal congestion, and inflammation. And this can decrease the narrowing and the obstruction with asthma. So used for long-term asthma, exercise-induced bronchospasm, and allergic rhinitis. It works by suppressing the effects of leukotrienes. The adverse effects of this, very, very, very big deal. Suicidal thoughts or depression. So I would want to monitor that before I administer it and then after treatment. It would be contraindicated in somebody who has suicidal thoughts, right? So that would be very important for me to assess. Um, the it is interesting the medications that can cause those side effects, which is why it's very important for you to learn that because that would be awful for you to administer that and not know that and that happen and you not be able to say whether or not that was the impact, you know. Um, So for to administer this, they take it once daily in the evening. It can be in oral tablets, chewable, or in granules. The granules, they can mix that up, put it in ice cream, pudding, applesauce, whatever, and take those. Um, and if they're using it to treat exercise-induced bronchospasm, it needs to be given 2 hours before exercise in order for that to be effective. So these are some examples of a combination of glucocorticoids and the long-acting beta-2 agonist. Okay, so some examples of that is Advair, Symbicort, Dulera, and you can see here, here's my beta-2, here's my glucocorticoid. Okay, so those are together in one medication. Those are generally used for long-term asthma maintenance and not for acute things. I don't know. I would have to, I don't know. Okay, I'll look. I don't know. Um, so for asthma, there are different classes of it. Our goal in treating, in addition to the things that we said that we would monitor their actual lung function, and ability to expand, contract, whatever, get rid of air, will be monitored. I'm not going to expect y'all to know those things. But our goal is that I'm going to treat acute events and then prevent the reoccurrence. Okay. So they'll be on those long-term steroids. They can have those rescue inhalers should they need that. Depending on how their asthma is being controlled, you might have more strenuous treatments, and then that can change depending on that. Very important if I have a patient who has allergic reactions, and that's why I'm giving them these medications, which can cause some pretty severe side effects. Very, very important to teach them all the things to do to control their allergies that aren't medication, right? Avoid those triggers. If it's pets, if it's dust mites, if it's whatever that might be, exercise, of making sure that you are taking care of yourself, and avoiding those things to the best of your ability, or at least like taking the medication before you exercise to prevent that. For treating asthma exacerbation, I'm going to give them oxygen. I'm going to give them the rescue inhaler. We wait 5 minutes. We give them the glucocorticoid, and then they also usually will get the ipratropium. And again, we'll wait 5 minutes between those. If they have if they have exercise-induced asthma, we said for the Monteliacast, we'll give that 2 hours before they exercise. And then the beta 2 should, if they're using that for treatment of it, the beta 2s, albuterol, whatever, should be given immediately before they start exercising, okay, in order to open those bronchioles up and prevent that. And that is diagnosed by if they have a bronchospasm within the initiation of exercise. Okay, feel like that's self-explanatory. Once again, just avoiding those things. Usually people get pretty strict if they have severe allergies. They'll get pretty strict instructions on making sure that you wash things frequently, avoid all of that. My baby has terrible allergies, and she is a stuffed animal fanatic. And it is like an entire event that we have to, because I don't want to deprive my precious little angel of stuffed animals, that I have to wash them with very hot water and make sure that she's not sleeping with them and that sort of thing. For COPD, these also can be measured by severity, and then the level of impairment, it really is directly affected by you will see that on your assessment. But they can go through moments of exacerbation. Our goal is to, first of all, prevent exacerbations if we can, make sure that their lung function is as optimal as possible. In order to treat these, we give bronchodilators, glucocorticoids, phosphodiesterase 4 inhibitors, and if they have an exacerbation, they might need those bronchodilators in order to handle acute symptoms. So if this is like them normally living, this is just their day-to-day life, things that they have to do to manage to keep them from an exacerbation. This is if they're acutely have a more severe occurrence, okay? So in those times, we'll give systemic glucocorticoids. So they'll get IV or PO, glucocorticoids, antibiotics, and then they get supplemental oxygen. Sometimes, or probably most of the time, that might be an improper statement, but people who have COPD are going to be on oxygen. Very, very risky, and very important to closely monitor their oxygen levels, because they actually can die from too much oxygen because their body is dependent on carbon dioxide. Okay. So most of the time, their O2 sats, where we're looking for 100 would be our goal, right? Like I at least want something above 95. Theirs might be somewhere between 88 to 92, and they're going to be all right. They're going to be, because they're used to living at a lower oxygen state. Okay. So the nurse is providing instructions to a client who has a new prescription for albuterol and beclomethasone inhalers for the control of asthma. Which of the following instructions should the nurse include in the teaching?
Yes.
Very good. B, I'm taking that beforehand, right? My steroid's going to come second. The rescue inhaler is what I'll give first. Okay? A nurse is teaching a client who has a prescription for long-term use of oral prednisone for treatment of chronic asthma. The nurse should instruct the client to monitor for which of the following manifestations as an adverse effect of this medication. Y'all saying B? They could gain weight. It does. Have y'all ever been on steroids? They make you the hungriest person on the planet. You want to eat everything in sight. So weight gain is a side effect, and I don't think I've said that up to this point, but it is. Nervousness, I get you. You're not wrong. It does increase your anxiety. So, I said the answer's A, but I will accept B. Yep. A nurse is providing instructions to a client who has a new prescription for albuterol PO. Which of the following instructions should the nurse include? So, so B, tremors are an adverse effect of this medication. That's correct. I already knew this was going to be an issue. I think this was just tricky. Like, what the heck does abort mean? But yeah, that is, that is, it is used to treat an asthma attack. If that's what you were saying, I'm with you.